patients. Dr. Evans, can you give us some guidance with respect to your experience with fluid management?
Sure. Fluid management always comes up in the management of patients who are acutely ill and hospitalized, certainly with sepsis and certainly with COVID. And there's been a fair amount of lengthy debate as to whether COVID is sepsis, which I would say it is. It's infection and infection-induced organ dysfunction. I think one of the key tenets there is, like Dr. Everhart said, is to correct a volume deficit if it's present. We don't want to give fluids just for the sake of giving fluids, but if there's a volume deficit present, if you think the patient is hypovolemic, and that's a contributor to their hypotension, then certainly I would give them fluids, as the same way that we would address that with a patient who presents to the emergency department with, probable bacterial sepsis. There is a lot of discussion about then, once a patient is sort of acutely resuscitated, about then what should your volume goals be. And there's good observational data suggesting that ICU patients who have a cumulative positive fluid balance after initial resuscitation in the ICU do worse than patients who don't. And whether that's causal or not, I think remains to be seen at this time. It's certainly something that has been observed repeatedly as an association, but causality remains, I think, unproven. However, many of us have moved to saying, once a patient has been initially resuscitated from a component of sepsis and hypovolemia, and then they're now hemodynamically stable, moving to a phase of actively de-resuscitating that patient. And so I think in general, the approach to patients with pneumonia, including COVID pneumonia and including ARDS, with that high component of extravascular lung water, that giving them some diuretic and trying to tolerate them being relatively conservative in their fluid balance, if their hemodynamics permit you to, is a wise approach. I'd be interested in what the rest of the panel does, of course.
Great. Does anybody have anything else to add with respect to volume management on the panel?
I will say that we also are of the mindset of once they are fluid stabilized and hemodynamically stable, we do start that de-resuscitation phase to try and minimize the amount of fluid that they have on board, just like Dr. Evans said.